blindingly bright lights, the green sterile drapes. It's all so visual.
It's the theater of the operating room.
Yeah, exactly.
And truthfully, all those rituals are absolutely vital. But they are not the whole story.
Not at all. We tend to think that the safety of that operation comes down entirely to, the steadiness of the surgeon's hand and the sterility of those metal instruments. And don't get me wrong, those are huge.
Of course.
But today, we're looking at a stack of research that suggests there is an invisible shield raised right before the first cut is even made.
A chemical shield.
A chemical shield that, in many ways, determines whether you walk out of there healing perfectly or, facing a complication that could haunt you for a year.
We are talking about surgical prophylaxis.
Which sounds incredibly technical, but our mission today is to break this down. We're looking at how modern medicine uses antibiotics not to treat an infection, but to stop one from ever even thinking about starting.
And it's a much more complex chess game than just giving the patient a pill.
Right.
We have to look at timing, the specific bacteria involved, the patient's own biology, and the specific type of surgery. It is a very precise science of defense.
So let's unpack this. We have a few different terms floating around in these sources. We see prophylactic, presumptive, and therapeutic. I feel like distinguishing these is really step one.
It is absolutely essential. Think of it as a timeline of war. Prophylactic is the preemptive strike.
Okay.
This is antibiotic therapy administered before there was any contamination of sterile tissue. The enemy, it isn't there yet, or at least they haven't breached the wall. The goal is zero infection.
Okay, so that's the shield we were talking about.
Right. Then you have presumptive therapy.
Presumptive.
This is when the surgeon suspects an infection is brewing, but it's not proven. It's treating a maybe. You're sort of firing into the dark because the risk is so high.
And therapeutic, what's that?
That's treating a definitely. The infection is established, the enemy is inside the gates, and now you are fighting to kill an existing active infection.
Got it.
But for our deep dive today, we're almost exclusively focused on that first category, prophylaxis.
Preventing the problem before it even exists.
Exactly.
Because once that problem does exist, it has a name. A surgical site infection or an SSI.
Correct. And defining an SSI is interesting because there is a ticking clock involved. Generally, for an infection to be classified as a surgical site infection, it has to happen within 30 days of the operation.
30 days. So if I get an infection at the scar site on day 31, technically that's not an SSI.
By the strict definition, usually not.
Huh.
However, and here's where it gets really interesting, if the surgery involved putting something foreign into your body,
Oh, like an implant.
an implant, a prosthesis, a new hip joint, that window extends dramatically.
How long are we talking?
1 full year.
What? A whole year?
1 full year.
Wow. So you could be walking around on a new knee for 11 months, get a deep infection, and it's still considered a result of that initial surgery.
Exactly. Because foreign bodies completely change the rules of engagement for bacteria, which we'll definitely get to.
Okay.
But broadly, these infections are categorized as either incisional, meaning superficial skin, or the muscle underneath, or organ space, which is much more serious.
And that would be something like...
That's something like meningitis after brain surgery, a total disaster.
Okay, so the stakes are clearly very high. But doctors can't just give massive doses of antibiotics to every single person who walks through the door, right? I mean, that leads to resistance and all kinds of side effects.
Absolutely not.
So how do they decide? Who gets the heavy artillery?
This is where risk assessment comes in. And the text outlines a classic system developed by the NRC, the National Research Council. They stratify every single surgery into 4 classes based on how clean the procedure is.
I love a good classification system. Let's run through them. Class 1, clean.
This is the best case scenario. You aren't dealing with any inflammation. You aren't cutting into the respiratory tract, the gut, or the urinary tract. It's an elective case, no breaks in technique.
So like fixing a hernia or a simple knee surgery, something like that.
Exactly. And surprisingly, for many of these clean procedures, antibiotics aren't actually indicated.
Really?
Yeah. Unless it's a high-risk procedure or it involves an implant, the risk is just so low you don't really need the drugs.
Okay, next rung down the ladder. Clean-contaminated, which that sounds like an oxymoron.
It does sound contradictory, doesn't it?
Yeah.
But what it means is that you are doing a controlled opening of those dirty tracts, the gut or the lungs, but there's minimal spillage.
Ah, so you meant to go there and you kept it tidy.
You kept it tidy. You're removing a section of the colon, but you keep it very contained.
Right. And for that, you need antibiotics.
Precisely. Here, prophylactic antibiotics are absolutely indicated.
Okay.
Then you have class 3, Contaminated, this is where things start to get messy.
Okay.
There's acute inflammation, or maybe a major break in sterile technique, or major spillage from the gut.
And finally, the last one, class 4. Dirty.
Dirty means the infection was already there before the surgeon even arrived.
So you're walking into a war zone.
You are. Old infection, pus, dead tissue. In this case, you aren't doing prophylaxis anymore. You are doing therapeutic treatment because the patient is already infected.
So that's the baseline. But the source material mentions this fascinating study called scenic.
This study on the efficacy of nosocomial infection control.
Right. And it suggests that just knowing if a wound is clean or dirty isn't enough.
No, it's not nearly enough. The scenic project added a multiplier effect to our understanding. They found that within the same category, say a clean contaminated surgery, the infection rate could vary by a factor of 15 depending on other risk factors.
A factor of 15, that's massive. What are the variables?
They identified 4 big ones. First, is it an abdominal operation?
Okay.
The belly is a playground for bacteria. Second, does the operation last longer than 2 hours? Time is the enemy.
Because the longer the wound is open, the more chance for bugs to get in.
Exactly that, and also the more tissue damage occurs, the more places for bacteria to hide.
Makes sense. What's number 3?
Third, is it a contaminated or dirty procedure? That's from the NRC classes. And fourth, does the patient have more than 3 underlying medical diagnoses?
So if you have a patient with diabetes, heart disease, and hypertension, they are automatically at a higher risk.
Correct. And they also layer in something called the ASA score. That's the American Society of Anesthesiologists score.
ASA score.
If a patient has an ASA score of 3 or higher, which means they have severe systemic disease, the risk of infection just spikes. So a surgeon looks at the wound, but they also have to look at the patient and the clock.
Okay, so we've assessed the threat level. Now let's talk about the enemy itself. Where are these bacteria coming from? I think most of us assume they're, floating in the air or crawling on the surgeon's gown.
And that does happen. That's called exogenous contamination.
Yeah.
From the outside. But usually, the call is coming from inside the house.
The endogenous threat.
Right. Most surgical site infections are caused by the patient's own flora.
Our own bacteria.
Our own bacteria. We are covered in them. Our gut is full of them. When you make an incision, you are often providing a superhighway for your own bacteria to travel to places they should not be.
This concept of translocation that's mentioned in the text is really creepy but fascinating. Good bacteria gone bad.
It is. Normal flora is helpful when it stays in its lane. But if you move a bacterium from the skin, where it's harmless, deep into a joint capsule or the bloodstream, it becomes a pathogen.
Right.
And on the flip side, if you use too many antibiotics, you could kill off the protective flora, the good guys, and allow the bad guys to overgrow.
So who are the usual suspects? If we looked at a police lineup of surgical infections, who is public enemy number 1?
Staphylococcus aureus. Staph is the king.
Staph aureus.
Along with its cousin, Coagulus negative staphylococci. Then you have the gut bugs. Enterococci, E. coli, and Pseudomonas. Those 5 make up the vast majority of infections.
You mentioned earlier that having an implant changes the rules. The source says that having a foreign body greatly decreases the number of bacteria required to cause an infection. Why is that?
It's a matter of leverage. So normally, your immune system is great at cleaning up stray bacteria. But bacteria can adhere to foreign materials, plastic, metal, and form these things called biofilms.
Biofilms, like a shield for them.
Like a fortress where your immune cells can't reach them.
Yeah.
So while it might take, say, 100,000 bacteria to infect healthy tissue, it might only take 100 bacteria to infect an implant.
100. That is terrifying.
It's a huge difference.
It really highlights why this shield we're talking about is so critical. So let's talk about raising that shield. The rules of engagement.
Rule number 1, timing is everything.
The golden rule.
The antibiotic must be present in the tissue before the incision is made, not after, not halfway through, before.
There's a specific directive in the text that I found really interesting. It says, do not order drugs on call to the OR. Can you explain that?
This is a classic logistical trap.
Okay.
On call to the OR means the nurse on the floor gives the drug when the operating room calls to say, send the patient down.
Right.
The problem is, transport can be delayed. The elevator gets stuck. Pre-op holding takes too long. By the time the surgeon actually cuts, the antibiotic levels in the blood might have already peaked and started to drop off.
So the shield is already fading before the battle even starts.
Exactly. So the rule is, administer with anesthesia just prior to the initial incision. You want the blood concentration to be peaking exactly when the knife breaks the skin.
And what if the surgery takes a long time? You mentioned earlier that surgeries over 2 hours are a higher risk.
Then you have to redose. You have to re-up the shield. You need to maintain bactericidal concentrations throughout the entire procedure.
Okay, so we know when. Now, what are we using? If you had to pick a weapon of choice from the armory, what is it?
Cefazole.
Cefazole, it sounds like a character from a fantasy novel.
It's the workhorse of surgical prophylaxis, a first-generation cephalosporin,
And why is it the favorite? What makes it the go-to?
because it is laser-focused on the main enemy we just talked about, the skin flora.
Staph aureus.
Staph aureus and Staph epidermidis. It's safe, it's effective, and it gets into the tissue really well. For most clean procedures, cefazolin is the gold standard.
But surely it can't kill everything. What if you're operating on the gut where those nasty anaerobes live?
Then you need a different tool. Cefazolin doesn't kill anaerobes. Those are bacteria that live without oxygen. So for gut surgery, we often switch to cefoxitin or cefauditin. They have broader coverage.
And what about for the patients who are allergic to penicillin or beta-lactams, or if the hospital has a huge MRSA problem?
Then we bring in the big gun, vancomycin.
Vancomycin.
But we try to reserve vancomycin. We don't want to use it if we don't have to, because we don't want to breed resistance to our last resort drugs.
Right.
Or we might use clindamycin as another backup.
Okay, so we have our timing and we have our weapons. Now I want to do a deep dive into the specific battlefields. The text goes through different types of surgery, and the rules change for each one. Let's start with the stomach. Gastroduodenal.
This is an interesting one because the stomach has its own natural defense mechanism. Acid.
Right, the pH.
The pH is so low that most bacteria just can't survive there.
So usually the risk is low.
Usually, yeah. But if the patient has a condition that raises the pH, like an obstruction or gastric bleeding
Or if they are on acid suppression therapy, which so many people are.
Exactly.
Yeah.
All those proton pump inhibitors. If the acid is suppressed, the bacterial count goes up. That moves the surgery into the clean-contaminated category, and prophylaxis becomes necessary.
Moving down the tract, the biliary tract, the
Yeah.
gallbladder.
Here, the targets are different. They're E. coli and Klebsiella.
Right.
But here's a surprising fact from the text. For a low-risk, elective laparoscopic cholecystectomy, that's just removing the gallbladder through small keyhole incisions. Antibiotics offer no benefit.
Really? None?
If the patient is low risk, the data says you don't need them. Yet, many surgeons feel, naked without them. It's a hard habit to break. But the science says, not recommended.
That is surprising. Okay, let's go to the high-risk zone. Colorectal surgery?
This is the danger zone. The colon is absolutely packed with anaerobes. Without antibiotics, the infection risk is substantial.
The text mentions a controversy here regarding PrEP. I feel like everyone who has had a colonoscopy knows about the PrEP.
Oh, yes. The mechanical bowel prep. Drinking liters of polyethylene glycol to physically flush out the system.
Right.
Most surgeons do it. But the text notes that its ability to actually reduce the bacterial load to a meaningful degree is controversial.
So it cleans out the pipes, but not the bacteria on the walls of the pipes.
That's a great way to put it. It clears the solids, but the bacteria remain.
So they use a chemical attack instead.
A double attack, actually. This is one of the few times we use oral antibiotics.
Yeah.
The day before surgery, the patient takes neomycin and erythromycin.
At very specific times, right? I saw that.
Yes. 1 p.m., 2 p.m., and 11 p.m. The goal is to sterilize the inside of the gut lumen. Then, right before surgery, they get the IV antibiotic cefoxitin or cefaudican. You hit them from the inside and the outside.
It's a coordinated stripe. What about an appendectomy? That's a super common surgery.
Similar logic. The appendix is part of the gut, so you need anaerobic coverage. Epoxitin or cefoxitin.
Got it.
And remember the time limit we talked about. If that appendix surgery takes longer than 3 hours, you need a second dose of cefoxitin.
The redosing rule. Right. Let's switch gears to urology. Kidney stones, prostate surgery.
The golden rule here is sterile urine. If the urine is sterile, the risk is quite low. The main threat is E. coli.
But there are exceptions.
Yes. If you are doing a 2RP, that's a transurethral resection of the prostate or shockwave lithotripsy to break up stones, you always give prophylaxis. It's just too invasive to risk it.
Okay, gynecology. C-sections and hysterectomies. This seems like a big area.
C-sections are fascinating because there was this long-standing debate about timing.
The controversy about the baby, right?
Right. For a long time, surgeons waited until after the umbilical cord was clamped to give the antibiotics.
Why was that?
The fear was that the drugs would cross the placenta and potentially mask an infection in the baby, making it harder to diagnose.
That sounds logical. I mean, you want to protect the newborn.
It does sound logical, but the data showed that giving the antibiotics before the incision, treating the mother earlier, reduced infections for the mom significantly without actually harming the baby.
So the benefit to the mother outweighed the theoretical risk to the baby.
Exactly. So the recommendation now is cefazolin, 2 grams right at the start.
And for hysterectomies.
It depends on the approach. A vaginal hysterectomy has a higher infection rate than an abdominal one because, well, the vagina is not a sterile environment.
Right.
But regardless of the route, vaginal or abdominal prophylaxis is recommended for both.
Now, this next one surprised me. Head and neck surgery. I think of the mouth as being pretty dirty bacteria-wise.
It is. The mouth is full of anaerobes. But the distinction here is about the mucosa.
Okay.
If you were just pulling a tooth or doing a clean procedure like a parotidectomy, the risk is low. But if you are cutting through the mucosal lining, essentially opening the barrier to the mouth's interior, the risk skyrockets.
And there's a specific dosing note here for cefazolin that caught my eye. You said earlier cefazolin doesn't kill anaerobes, but for head and neck, they use it.
This is a cool pharmacological trick. You're right, cefazolin isn't usually an anti-anaerobe drug. But if you give a high enough dose, 2 grams, the concentration in the head and neck tissues gets so high that it actually does inhibit those oral anaerobes.
So it overcomes its own weakness through brute force concentration.
That's exactly it.
That's clever. Okay, 2 more big categories. Cardiothoracic, heart surgery.
Technically, heart surgery is clean. You aren't cutting into the gut. But the consequences of an infection in the middle of the chest are catastrophic.
Correct.
Infection of the sternum or the mediastinum is an absolute disaster.
So they don't take any chances.
0 chances. They use cefazolin, but they are very strict about weight-based dosing. If the patient is over 80 kilograms, which is about 176 pounds, they bump the dose up to 2 grams.
And how long do they keep the antibiotics going?
Up to 48 hours, but not longer.
Not longer, why not?
The text is very clear on this. Extending beyond 48 hours does not lower infection rates. It just breeds resistance. More is not better.
Got it. Okay, finally, orthopedics. We touched on this with the implants.
Joint replacements, hip fractures. The primary targets are skin flora. If bacteria get on that new metal hip, it's game over.
You might have to take it out.
It might have to remove the whole joint. So cefazolin is standard. But here's a critical distinction. If a patient comes in with a compound fracture, that's a broken bone sticking out through the skin.
That's nasty.
That is not prophylaxis anymore. That is contaminated wound. You treat that as a presumed infection. You don't just give 1 dose.
Yeah.
You treat them for days.
Okay, so we have this incredible playbook. We know the drugs, the timing, the specific enemies. But as we know, the weak link in any system is usually the human element. How do hospitals actually make sure all these rules are followed?
That is the implementation challenge. It's huge. You can have the best science in the world, but if the anesthesiologist forgets to hang the bag or the surgeon orders the wrong drug, it all fails.
So how do you herd the cats?
Standardization. You have to standardize everything. You don't let people freelance. You create pre-printed order sheets that have the correct choices checked off by default.
So you make it harder to do the wrong thing than the right thing.
That's the goal. And you fix the delivery system. You physically place the antibiotics in the holding area or on the anesthesia cart so they are within arm's reach. You don't want someone running down to the pharmacy 5 minutes before incision.
And checklists. I assume those play a role.
Checklists are huge. Visual reminders. And finally, feedback. This one is really powerful.
Feedback.
You have to tell the surgeons their stats. You show them their infection rates. If a surgeon knows their personal infection rate is higher than their colleagues, well, competitive nature kicks in. They start following the protocol.
It's amazing how much psychology is involved in high-end medicine.
It's all about systems. The invisible shield we started with isn't just the drug. It's the system that ensures the drug is there at the right time.
So after this whole deep dive, what does this all mean for us? What's the big picture?
I think it brings us back to that delicate balance. We are walking a very fine tightrope. On one side, we have the risk of these devastating, life-altering infections, and we use these powerful drugs to stop them. But on the other side, we have the risk of overuse. The text emphasizes stopping the antibiotics quickly, usually within 24 hours.
Because if we leave the shield up too long?
We create superbugs, we cause side effects. The precision required is just immense. The right drug for the right patient at the right weight, at the exact right minute before the knife drops, and then stopping it exactly when it's no longer needed.
It really changes how you look at surgery. It's not just the physical repair, it's a biological war being managed in real time.
Absolutely.
Here's a final thought to chew on. The text mentioned that for some low-risk laparoscopic procedures, antibiotics offer no benefit. As technology gets better, and as we do more surgery with robots and tiny incisions, are we heading toward a future where preventative antibiotics become obsolete for routine cases?
Hmm.
Could the sterile technique eventually become so perfect that the chemical shield is just unnecessary?
That is the ultimate goal, isn't it? To make the intrusion so minimal, so clean, that the body's own defenses are more than enough.
Something to think about. Thank you for listening to this deep dive into the invisible world of surgical safety.
Thank you. Stay curious.
See you next time.